Our next project, entitled Combined Antiplatelet and Novel Oral Anticoagulant Therapy, is increasingly utilized but associated with worse limb outcomes and equivalent survival compared to antiplatelet and warfarin and antiplatelet therapy alone after suprainguinal bypass for peripheral arterial disease by Dr. Syed Zaidi and colleagues from Southern Illinois University.
Thank you. Good afternoon, everyone. I won't repeat the title again. Is this next? Yeah. Okay. I have nothing to disclose. So, why do we prescribe NOACs? Recent trials have shown combined antiplatelet and NOAC therapy reduces a combined endpoint of acute ischemic limb and cardiovascular events compared to antiplatelet therapy alone following infrainguinal revascularization in particular. Now, the efficacy of combined antiplatelets and NOACs after suprainguinal bypass is unknown. So our objective was to compare long-term graft and limb outcomes and overall survival in patients treated with antiplatelet plus NOAC versus those treated with antiplatelet therapy alone after suprainguinal bypass. So our methods. Our inclusion criteria, we retrospectively analyzed suprainguinal bypasses in the VQI database from 2014, when NOAC was first recorded, to 2021. We excluded any patients who lost their primary patency before discharge from their index procedure, or those without complete long-term follow-up. The intervention or the comparison was comparing the suprainguinal bypass patients discharged on antiplatelet plus NOAC compared to those discharged on antiplatelet only. Primary outcomes were long-term graft patency, major adverse limb events defined as major amputations and reinterventions, and overall survival. So we start off with 14,005 patients extracted from the VQI database within those 8 years. And once the patients that met the inclusion criteria and were discharged in either antiplatelet or antiplatelet plus NOAC were around 12,000 in the antiplatelet group and about 900 in the NOAC group. We further excluded those patients that were discharged on any patency level other than primary, and further excluded those patients who did not have complete follow-up. And we end up with 6,712 in the antiplatelet group and 401 in the antiplatelet plus NOAC group. We did further propensity score matching, resulting in 1,000 in the antiplatelet and 401 in the NOAC group. So, statistical analysis was done using propensity score, univariate survival analysis, and multivariate analysis in the usual fashion. P-value was less than 0.05. So, just wanted to highlight the change in antiplatelet and NOAC and warfarin use over time, at least during our study time period. The rates of antiplatelet usage was pretty steady over these 8 years, whereas warfarin steadily decreased and NOAC was steadily increasing in usage. So just a select few patient characteristics I wanted to further highlight. The NOAC group had a statistically significantly higher rate of non-ambulatory patients, and the NOAC group additionally tended to have more patients who underwent prior carotid interventions, prior bypasses of any kind, or a prior major amputation, a BKA or AKA. Some other operative characteristics that were interesting to note. The NOAC group had more patients with a axillary artery bypass graft origin, and their procedures on average tended to be more urgent or emergent than the antiplatelet group. So, on to our main outcomes. For primary patency, at 1 year univariate analysis, we found the NOAC plus antiplatelet group had a statistically significantly reduced survival primary patency rate compared to antiplatelet alone. As you can see, 79% at 1 year compared to 87% approximately at 1 year in the antiplatelet group. This is also extrapolated up to 500 days. Now, on multivariate analysis, we did find that NOAC use, prior bypass, diabetes, and an acute ischemic limb presentation all were independently significant predictors of a reduced primary patency. concerning primary cystic patency at a time of 1 year. We found on univariate analysis that, again, NOAC use was associated with reduced primary cystic patency. The multivariate analysis showed that NOAC use, again, prior bypass, and a history of diabetes were independent predictors of reduced primary cystic patency. Concerning secondary patency, once again, NOAC was associated with a statistically significantly reduced secondary patency rate, though not necessarily as much of a clinically significant reduction compared to the previous outcomes. And on multivariate analysis, NOAC use, again, prior bypass and a rest pain presentation was associated with, or were independent predictors of reduced secondary patency. So again, at 1 year univariate analysis, NOAC use was associated with an 80% major adverse limb event-free survival rate, which is lower than the antiplatelet group. We found several independent predictors on multivariate analysis. NOAC use, prior bypass, patient being non-ambulatory, a rest pain or tissue loss, or acute ischemic limb presentation, all were independent predictors of increased major adverse limb events. And on the outcome of major amputation-free survival, NOAC, again, was associated with reduced amputation-free survival at 1 year. Again, on multivariate analysis, patients being non-ambulatory, having a axillary artery bypass graft origin, or a tissue loss or acute ischemic limb presentation were associated with increased rates of major amputations at 1 year. Overall survival was just done using univariate analysis, and the NOAC group had a 89% overall survival rate at 1 year compared to a 91.3% overall survival rate in the antiplatelet group. So, a few limitations of the study. One, it's retrospective in nature. We can't determine why one group was prescribed NOAC plus antiplatelet or versus why one group was only prescribed antiplatelets. There may be additional unmeasured confounders which aren't captured from the data set we required from the VQI database. And not all NOACs were captured over the study period, nor was a dosing known. We did find that warfarin ultimately had similar outcomes as NOAC therapy, but we ultimately did not include it in the final analysis due to its decreased usage over time. So, in conclusion, combined antiplatelet and NOAC therapy after suprainguinal bypass is associated with worse limb outcomes and patency, but equivalent survival, statistically significant survival, compared to antiplatelet therapy alone. NOAC use in suprainguinal bypass has typically been extrapolated from infrainguinal data and can't be recommended for routine use based on our experience. Additional prospective investigation is required to determine the role of NOACs in optimal antithrombotic therapy after suprainguinal bypass. Thanks.
Rumi Pfizer, University of Minnesota. Thank you for that presentation. Dr. Zaidi, is that it?
Yeah. Yes.
Yeah. So, do you really think that these are equivalent patients?
No, they're not. I mean, the patients in the NOAC groups, they were sicker. They tend to be non-ambulatory. They were higher likelihood of having failure or amputations. That being said, we did find, even on multivariate analysis, just being prescribed NOAC was a little.
What you're not collecting is that these patients had probably a presumed hypercoagulable state or an increased risk of thrombosis, poor outflow, something like that, right? We don't put people on anticoagulation for an aorta by fem normally. So you're dealing with a completely different patient population. So I'm a little concerned that if you publish this, you're you're probably not comparing apples to apples, and you're going to give the recommendation that patients shouldn't go on Xarelto or whatever.
So not necessarily not to recommend, but to be a little more discriminate in determining who should get NOACs, who shouldn't.
And what you should be discriminating on is what is the risk of a bleeding complication. That's what I would think is a bigger deal. If you're seeing more thromboses, I think you're dealing with more aggressive native disease for the patient.
That's
Right? Second question, when you're comparing Coumadin versus something like a Xarelto, are you comparing like therapeutic Xarelto, or are you doing the 2.5 milligram BID?
The assumption is the vascular dose of Xarelto, but again, in the VQI database, that
Right.
dosage wasn't captured, so we couldn't really analyze that.
Yeah, so that's a very different level of anticoagulation.
Of course.
So I think I can speak to a few of those things. Those Will Robinson, I'm the senior author on the paper. Rumi, you bring up a lot of good points. I think I'd probably put a few caveats on things. So we do know that NOACs are being used a lot, and we don't have a lot of data for their use. You bring up a lot of good points there. Certainly, we can't identify hypercoagulable states. Do we know every anatomic aspect about these patients at the VQI? No. But we did control for all kinds of things like recipient artery, whether it's an iliac, femoral, popliteal. There is a fair bit of data you can control for. And I think by using both a propensity score matching and then a pretty aggressive multivariate analysis within that, you can't do much better shy of a randomized trial, is the bottom line. And if you look at the randomized trials, we actually don't have any of that information either. So we know that it's tons of patients. Randomization takes care of, making the confounders equal, but it still doesn't tell us the anatomy that informs our everyday surgical decisions. So I think there's certainly weaknesses, but I do think it adds a little bit, mostly being that it's hypothesis generating, study necessitating, more than it is definitive about saying you shouldn't use them. I think that's how we kind of go from here. But thanks for all your comments.
Thank you. In the interest of time, we got to move on. The speakers will be available for conversation later on. Thank you.